surprisingly tonight I can see my specialist colleague for the KSMC as well as Dr. Priya, yeah, and then some colleagues from the hospital tower, the government side as well, and of course for other GPs. Okay, so before I start my talk tonight, probably I would like everyone, yeah, just a quick one, 2 minutes, just do as a ice breaking each other. You can move around, okay, you can start now. So the things I want you to remember is to introduce your name, where you come from, and then have your friends ever dealing with any psychiatric problem before in the daily clinical practice, and write down or just remember what kind of psychiatric cases you ever encountered. Boleh? Okay? Okay, let's start now. Just move around, make more new friends here. Yeah. Just one icebreaker, okay? Yeah. I want to make the session less formal. Yeah. So now we'll try. Move around, Antidepressant, I don't use. I have 2 seconds. Okay, alright. Thank you so much, Dr. Priya. So I think here we can see the variety of the encounter by the specialist clinic, by the GP clinics, as well as clinic kesehatan. Yeah. So tonight, hopefully, my aim here is that. So let me introduce. I think just now I already introduced myself, right? So just call me Simon. So right now I'm running a clinic based in KK. You can see over the corner. This one. This is my clinic in KK at the best in Penampan, as well as this is my businesses. So besides that, I also run the psychiatry services in Rafflesia Medical Center, Utama Medical Center in Selatan, as well as KSMC. About the learning outcome for the first session, I hope everyone will try to appraise our psychiatry disease burden statistic in Malaysia. Try to understand, is it common or not with dealing with psychiatric cases in whole Malaysia. The second one is describe the common causes. Usually we want to learn about what makes a person mentally, unstable. Yeah. So here, after that, we try to identify the potential trigger factor. Trigger factor, that means what brings the patients come to us. Yeah. What is the triggering point at that time? Right. So when we talk about mental health, right, is not only we are not saying that the person is absent of the mental disease, but it's a state of well-being. It's overall very holistic approach. In a simple way to say that the person, he identifies his own ability, try to cope with the stress in life, and can work productively in the daily life. Then we say the person mental health is within the normal range. Okay? And the key component of a mental health usually comprises of three domains. The first one is our emotional well-being. The second one is psychological, and the third one is social. Like what you are doing just now is you try to interact with the people around you. So probably we can say that your social domain is intact. As compared to a person just sitting there, they want to talk, they are very shy. Yeah, we will say that probably this can be trained at all, because some people, they are very introvert. They are not they know the answer, but they don't want to share. Yeah, they're afraid of criticizing by other people. They're afraid of some negative comment by other people. So it's all we talk about is a psychological well-being. All right. So talk about the Malaysia statistic. I think this is one survey, our National Health and Mobility Survey done in 2019, which is about 4 years ago. And here you can see that the numbers of the depression among Malaysians, yeah, is about 2.3%. In the rough figure, is about 500,000. Yeah. But after the COVID-19 pandemic, I'm very sure everyone encountered the impact of COVID. So the number is keep rising to another level. I would say that this is already underestimated. About 500,000 population in Malaysia having clinically diagnosed depression. Okay. If we zoom in further in the whole state, according to the state, you can see that the Sabah here is actually a top rank number 4 in the whole country, which is having the highest prevalence of people with depressions. Okay, and then when here got the friends from clinic kesehatan kan, so usually you guys will encounter with antenatal checkup, the mother, or after that you have to follow up after delivery kan. So here, if we see the statistics, this is the last year, 2022. We talk about the silent struggles among the pregnant lady. So we noted more than 11% of the mothers having depressions after the childbirth. Sometimes we call it as a postpartum depression or antenatal depressions. I think Dr. Priya will agree with me. Okay. Thank you. So unfortunately, we see back the figure here. More than 90% mothers are aware, they don't know. Actually, they are having this kind of clinically depression, which is need our medical attentions. What we worry as a mental health specialist, we always worry about the complication or implication of risk. The risk here we are talking about is probably the self-harming or mother harm the baby, infanticide, it happens. Yeah. So with adequate support and the treatment, usually the mother will be recovered. Yeah, usually. And here, the next slide, you can see some data talk about the violence, yeah, for the women in Malaysia. And you see, the number is very surprising, so high. 500,000 the women in Malaysia ever experienced violence by their partners. And then here we talk about the divided into emotional violence, physical violence, sexual violence. Yeah, so it's very, very common. If you really take it seriously about the mental health related issue in Malaysia. Yeah, the data are there. Just the matter is that whether we're willing to provide or willing to take it seriously or not. For whoever the patient come to our daily practice, no matter it's the GP clinics, yeah, the specialist clinics or the government side. Okay. And then here, I also give some brief data, talk about the young children or adolescents mental health. Here is the survey is done in 2017. If you can see the suicidal risk among the adolescents, those with the girls, usually it's a higher prevalence compared to boys. It's more than 10%. That means out of 1 out of 10. Our teenage, the students in the secondary school, they ever experience suicidal thoughts, ideation, or they even attempted suicide. Okay, so I think this is a great burden to our country, yeah, because we spend a lot of resources to, in the education level, the system. So if we can provide the proper interventions to those students in the school, I think they'll have a brighter future. Okay, and here I would like to make a comparison. Just now I mentioned about 10%, right? The people in the school ever got the mental health, the suicidal risk in the school. But after 5 years, the government done another research, the survey, which is 2022, and then we found out that actually the number is keep increasing. 1 in 4 of our teenage, they feeling depressed. And some of them, the numbers of the suicidal keep increasing years by years. Yeah? I think the co-founder factor here will be the pandemic, the COVID pandemic. It brings a lot. Yeah? If I think here got some psychiatric doctors here, yeah, you guys can feel the influx of a young patient nowadays, 14, 15 years old, they come in struggle in terms of the depression, anxiety, or even insomnia. And the parents are very worried. Okay? So I would say that the mental health related issue is affecting everyone here. No matter you are small kids, you are adult, or even you are elderly, it's affecting everyone. So here I would like to share a paper, a systematic review of anxiety prevalent in the adult. Here we talk about the primary care, that means how common is of the anxiety issues seen by those GPs or the NOs in clinic kesihatan. So here the similar review, they comprise of 42 local studies, and then the prevalent they found about the generalized anxiety is about ranging average about 4%. Okay, for those depression is about 5%. Panic disorder, I'm not sure how, but it is very low, only 0.4. For my clinical experience, I think the GPs always refer me the case, mainly is about panic disorder. They've done a lot of medical investigations for a patient with SOB, chest pain, and then they've done ECG, everything normal. If not trusting, we can ask our physician Chong. What do you think the panic? Panic is what is it very common in your practice? Panic is all the cases. Okay, no worries. I'm even more panic now. What do you think the panic is all in your practice? Very common, right? Referred by the GPs. They come in with a lot of somatic symptoms of headache, dizziness, stomach, unspecific. They got a multiple somatic symptoms. After you've done every blood investigations, you realize it's normal. Then what happened to them? Then refer Dr. Rahul, psychiatrist. Okay. So, the next slide is talk about the economic burden. That means how expensive we want to treat a person. Let's say the schizophrenic patients. What do you guys think? Is it expensive or very cheap? Dr. Danish, what do you think? Is it economical wise? Thank you. So Dr. Danish sharing that is more efficient if you can treat them earlier, so you can prevent more relapses. So from here, the paper is a research paper done in Malaysia as well. We realized that this is they taking the number in year 2015 now. So number of schizophrenic patients in Malaysia about more than 15,000, and then average the mean cost per patient is about USD 6,500. It's converted now, it's more than 30 or 30K. So I would say it's not easy to treat, it's very expensive as well to treat those chronic mental conditions in our country. Alright, here is a very quick test, to identify, to try to understand yourself. You see there's a picture here in front of you. Anyone? Yes, Dr. Tan. Before we eat the dinner.
I see a half full glass.
Half full glass. Okay. Here you got the two answers. Either it's a half empty or half full. Here I will do the very quick survey. Who said it's a half full? Raise up your hand. Half full, half empty. Separuh penuh lah. Separuh penuh. 1, 2, 3, 4, 5. So the rest is a half empty lah. Yeah, I assume. Although
drink the glass only.
Drink the glass. Okay. So here is mainly I want to bring up about the way we talk, the way we perceive the things. Usually influenced by our brain itself. Sometimes with a different personality or different perceptions about the life, the past experience, we see the things differently. Actually, there is not any right or wrong answer for this. You can say it's half full, you can say it's a half empty. It depends. But there is one statement given. Yeah, they said if you're thinking about this is a half empty, that means you're always worried about the future. You're always thinking this is not enough for me. They cannot see, they cannot appreciate whatever they have. If you say it's a half full, that means you are kind of very contemplated about the current state of yourself. You always appreciate the things. You have a more positive thinking about the current situations, about your future. This is a very quick test for me to test everyone here. So I would say everyone, the way we perceive things is different, that's all. Okay? Alright. So remember our learning outcome for the tonight. We try to understand what is the common causes of our mental conditions. Usually, if a very general category divided into the biological, psychological, or social factors. They are the contributing factors. Usually they say if you have a depression, whether it's inherited from your family or not. A lot of patients asking me these questions. Dr. Simon, my father having a very severe anxiety. How high of chance having anxiety as well? He wants a number, but I cannot give it the Because here we are talking about the many multifactorial causes. You cannot only blame about the genetics. You also have to see about the confounding factors here. For example, the psychological. Like just now we did the test, right? Everyone, the psychological state is different. The way you perceive the things different. Then next thing we have to see about the social factor. About some people, they may having the financial issues, relationship issues, or workplace, or life event, or trauma. So it all shared together whether the person having the vulnerable toward the mental illness or not. Here we talk about the possibility. Yeah? Okay? If in the psychiatric world, we try to dividing the things more complex and more, because psychiatry, we are always thinking is very complicated about a simple case. Like a person, you ask, how are you? Then as a psychiatrist, we started to think, why she say she is good? After she paused for a few seconds. We try to psychoanalysis, try to analyze, but it's not true. Okay? So in the next slide is how we as a psychiatrist we try to define the cause. We make it more systematic. Okay? Usually we talk about the 4 factor model. It has been there for many years, but it's still valid until today. Yeah? So usually the first is a predisposing factor. That means whoever the factor, here like the genetics or the use of toxic during the pregnancy, it can be give rise to predispose a person toward, let's say, depressions. But it is not confirmed to happen 100% because we need to see the second factor is a precipitating factors. For example, like a recent loss or the school stresses, then you will precipitate the episode of depressions. Okay? If let's say a person come to you already depressed, you give the treatment already, then you keep thinking, you ask yourself, why this person is not responding to my medications? Is it something wrong? Yes, something is wrong. We see the perpetuating factor, that means whatever the conditions give rise to the continuity of the symptom. That means something is still persistent there. Yeah? So this is a component inside there. And last of all, I always emphasize about the protective factor. Actually, what is the strength of this person? Make her feeling better. Okay? Like it's more of a general lifestyle. Talk about the diet, the sleep, the physical exercise, or the resilience. Resiliency is one of the major factors. Nowadays, usually I will see among the young adult or in the school students. If you look back, resiliency, that means how much you able to bounce back from the failure. As compared like Dr. Priya, our senior consultant ONG, last night, he himself one day can handle a lot of patients. Yeah, more than 30, 40 patients. If the same scenario happened today, maybe the young doctor, we feel overwhelmed already. See so many patients cannot handle, very stressed. So here we talk about resilience. How much you can bounce back. Okay? So the last part is talking about the trigger factors. Yeah, trigger factors, that means at this moment, at the current moment, what happened to the patients? The life changes. It can be anything. That means patients have a very high vulnerable to the mental illness crisis that we talk about. So now, it's very important for every doctor to understand about the trigger factors. Yeah. If you cannot identify the trigger factors, you only treat the symptom only. Let's say the patient came in with a sleeping problem, you just give a Xanax on him, give a Alprazolam or lorazepam. It doesn't solve the problem at all. Because the trigger factor is still there, it still perpetuates the symptom. Okay? If you want to troubleshoot, you have to understand the patient as a whole person. Very holistic approach. Okay? So here the trigger can be anything like a couple just break up 2 years ago and then become very suicidal and hopeless about the life, having a high harm himself. Or a person, Grab driver, He suddenly lost a job because having a stroke, young stroke patients. It's a very significant for him. So it can be anything. So here the key message I would like to everyone to always appraise when the person comes to you. We not only see the symptom, but try to understand the story behind them. Probably the patient will be more engaged with you in the next sessions. Okay, so I think that's all. So we can enjoy our dinner for now. Thank you. learning outcome for these sessions, I will make it less than 1 hour. So we have to know what's the condition of anxiety, depression, psychosis. And then we try to recall what is the DSM-5 criteria to give a correct diagnosis according to the patient's symptoms and also the functions evaluations. And then usually we try to evaluate the suicidal risk. How do we assess a person when they come in or clinic as a suicide? Very quickly. And eventually we try to list down any psychiatric drugs we use in the clinics. Okay, so can we move on? Then, okay. So when we talk about anxiety, what do we understand about anxiety? Is it a normal reaction or is it pathological reactions? Maybe I like Dr. Chong because he always very fast finish the dinner. Finish earlier than you answer my question. What do you think the anxiety? Is it normal or abnormal? Let's see, this is starting to feel anxious already. What do you mean by abnormal? Okay, so Dr. Chong mentioned that if anxiety can cause a lot of problems, that is considered abnormal. Okay? Alright? So here, basically we have to understand the most common one. If you encounter a patient with a lot of symptoms, usually we go to the most common one. This never goes wrong. Okay? One of the anxiety disorder in the DSM-5 is panic disorder. Okay? And in the first session, we talk about panic disorder. Okay? Which is encountered by having almost every doctors here. But it's actually referring, according to the DSM-5, it's referring to the recurrent, unexpected panic attack. If let's say a patient he just lost a job or he just break up, it's not considered panic disorder because it's something triggered already. But panic disorder, the real definition is unexpected panic attacks. That means without trigger, patient just rest at home, lying on the bed, suddenly feel the SOP, chest pain. That is a panic attack. If a recurrent panic attack here is usually will reach a peak within a minutes, and then at least 4 of the following symptoms. For 1 up to 13, fulfilling at least 4, then you will say it's a panic attack. Okay? So next, the criteria is mentioned about you have at least 1 of the attack have been followed by the 1 month durations. 1 month. Okay? By the persistent anticipate or worry about the next attack or a significant amount of the change in behavior. Let's say the patient will try to let's say she's driving a car. Okay, some patient having the panic when the car stops in front of a traffic light. Okay, because it is surrounded by a lot of cars. The patient will feel that if what happened if I fainted now, no one will coming to rescue me. This kind of panic. Okay, she will try to avoid to drive the car. Right? Okay. So besides panic disorder, another common condition which you encounter in our clinic is generalized anxiety disorder. It usually happens in the patients who is much advanced in age, usually in the late 40s or even the elderly. On the presentation, they usually have excessive anxiety and worry about everything, at least 6 months durations. Okay, 6 month durations, and then the individual find it is very difficult to control. I feel I'm losing control. Okay, they cannot control it and worry. Okay, I'm worried about where is my son. I keep bring my son. I will keep worrying about what is dinner tonight, and then I will worry about what happened tomorrow. Where is my car key? Worry about anything for any 6 months. Okay? And then, of course, you have to fulfill at least 3 of the following symptoms here. For example, feeling always feeling up or age, very tired, very difficult to concentrate, irritable, muscle tension, and of course, insomnia. Tonight I will talk more about the insomnia problem since our design company is supply about the insomnia. So just now we covered the 2 most common anxiety disorder, which is panic or GAD. So next year I will talk about depressions. Okay, so depression is a mental condition characterized by the 4 symptoms of persistent feeling of sadness, emptiness, numbness of the emotions for at least 2 weeks. Okay, so when a person without crying, if a person is not crying, can we diagnose a person as a depression or not? Depression. What do you think? From here, the table. Let me repeat my question again. When a person comes to you, he is not crying, he is not feeling sad, is there any possibility we can say the patient having a depression? Can you explain more? Okay. Alright. Okay, thank you. Is there any other explanations? Any friends who would like to help out? Call for the helplines? No? Highly functional depression. Can you tell us more?
I don't really know why it's usually the person who has high functional depression is functional.
Okay. Alright, thank you. So one of the colleagues here mentioned about high function depressions. Yeah, and then mentioned about use of objective tools to scoring the severity of depressions. Okay? If we look back on the DSM-5, when we talk about depression or major depressive disorder, usually the patients have to fulfill either 2 of the criteria. Number 1 is a persistent depressed. Number 2, he lost the pleasure, he lost the motivations to do things he used to do in the past. Or we call it as an anhedonia. So just like you mentioned about the high functioning probably is pointed toward the anhedonia. He still can do work, but he had to work, he find no purpose. He don't know why he need to work so hard. He can't find the pleasure by every month he able to achieve the KPI, able to achieve the goals set by the company, but he can't enjoy it. Yeah, he's lost of pleasure he used to be. So we call it as anhedonic type of depressions. And then according to the study, it's up to 30 to 40% the patient is undiagnosed for those high functioning one. They come to work, but doesn't mean they can perform. They come to work, they punch in, they're just sitting there, ruminating about the worries, the performance. And then they punch out, they do nothing at home. They keep worried about they are not good enough, they are useless person. Yeah, these are all cognitive errors. Usually will happen among depressed patients. Okay? Alright. If we look at the anatomy in our brain, we believe that what happens in our brain, usually the area, the subcortical involvement, mainly is our amygdala here, mainly is controlling our emotion expressions, emotional regulations. Yeah, it connected to the hippocampus. What hippocampus? Hippocampus is a structure beneath our subcortical structure which control the memory. That means some patients when they listen to the very sentimental song, they will cry because they have the memory in the past. The song related to their own experience. If I play the same song to Dr. Priya said, what is the song is it? No. So it's a different it's a very important for everyone of us here as a doctor because it's involving the area which helps us to plan, to execute, to do the judgment call. Yeah? But if a person who is depressed, all these structures, they are very heavily influenced by this or all the chemical imbalance in the brain, and then the person cannot focus anymore like the last time. The person cannot make the decisions. The person having a difficulty to concentrate on the task given. Okay, so I hope here with a very simple way of understanding a person why the implication of a depressed. Okay, so the common causes here, there's a lot. Like just now we mentioned in the sessions 1. So mainly we are talking about the trauma here and use the past experience. And of course, other things like the grief, loss of a loved one, loss of the boyfriend, girlfriend, it can trigger or it can perpetuate the depressive episode. Okay? And the loneliness, here I realized that the loneliness, especially during COVID pandemic lockdown period, most of the elderly, they cannot go anyway. So there's a study research saying that the loneliness is one of the major contributing factors to depression among elderly after the COVID. Okay? And the chronic illness, like those are patients with diabetes, hypertension, heart disease, stroke patients, cancer patients, yeah, there's a causal relationship to cause depression. Okay? So the sign and symptom here, I think most of you understand about in their daily life it is heavily affected because they're always feeling fatigued, with decrease of energy, they cannot think clearly, or sometimes they say that I'm having a brain fog, I cannot see the things very clear. Okay? And biological symptoms including change of appetite or weight, and then cannot sleep at all during the night time, loss of interest in the activity they used to love, and we are most worried about the recurrent thoughts of suicide. It's more common in the depressed patients. So here I'm dividing the symptoms into the 3 domains. First, you can categorize in the emotional symptoms. Number 2 is the cognitive functions. Number 3 is the physical or somatic symptoms. Okay? Like some young patients, like we encounter is a married couple. They've been married for the past 10 years, no kids at all, and then the husband always said that he's very stressed at work. Yeah, the boss always gave a very high expectation. He wanted to pursue higher position in account because the boss is very demanding. Eventually, because something happened in the workplace, making this husband depressed. Then when depressed, all the symptoms come out. One of the more important is reduced libido. They mean no sex drive. And then started to have an argument with the wife. Yeah, wife said, you want a baby? But husband said, I got no mood. How to make a baby if no mood? Cannot make a baby. I think difficult like that. Okay? But after we address the depression, he received the treatment and some coping skill. Eventually, he responded well. And I think after a few months, the wife telling me that she got pregnant. I think this is how we wanted to help the patients, depending on what is their priority. Okay? So the common type of a depressive disorder, usually we encounter with this one, MDD, we call that short form MDD. If a patient having a persistent depression for at least 2 years, the function is okay, not severely affected, we call it as a persistent depressive disorder. And then sometimes we also encounter with a bipolar depressions. That means it's a depression, but it's a bipolar disorder type depression. Here it's very important for us to identify because it's always involved with a different management, different medication we have to use. Yeah. if let's say a patient come in with a bipolar depression, it's not recommended to treat just an antidepressant itself. It might make the disease worse. Yeah, remember that. So always try to explore any bipolarity symptom when the patient come to you depressed. Okay. And the other type will be the atypical depression. That means the guy just come to you, laugh, enjoy, but in the end of the day, go back home, he's super depressed. It's just like a put on a mask. Just act like nothing happened, very cheerful person in front of you, but in fact he's very depressed inside because sometimes it's a small depression. Okay, it's very difficult to identify these things, but we have to see it very holistically because the patient sometimes they will give us some subtle sign when we talk to a person. Yeah. Okay, subtle sign I will say that when there's a psychiatry, we always do the mental state examinations. That means not only we see the person talking, we also see the person how he's behaved in front of us. Right. Thinking. Okay. So this is a non-verbal cues we learn. So I move on very quickly to the suicidal risk assessment. Okay. Here is a person always will come in the crisis. When it comes to the crisis, some of them will try to avoid to facing the problems. Some of them will choose to harm themselves. So how do we encounter with this kind of patients? This one I talk about the primary level, very general. Okay? So first of all, start with the history first. Yeah, history of the past self-harm or history of the mental issues, family history of the suicide. Usually will predispose the person having a higher risk of suicide. Okay? If a mother of this patient ever try to harm herself in the past, if you ever ask her, that means the patient currently, one of the factors is contributing from family history of the suicide. Okay? Of course, we have to see any anticipated factors here. Like some of the clients, they see the anniversaries. I got one client, they're feeling very depressed, they're feeling hopeless about the life. Then they choose when the birthday comes. They choose to end their life. So here I talk about the anticipated anniversary. One of the example, yeah. Okay, the loss, the stressful event, and access to means. In Malaysia here, we study about the type of the self-harm actions. Most of the Malaysians, what they use to self-harm or try to attempt suicide. Yeah? As compared to the Western country, they usually accessing the weapon like a gun, all that is very little. In Malaysia here, usually in the previous study, we found out that most of patients in Malaysian population that tends to use a method of jumping, jump from the high floor, overdosing, or even use a paraquat. Nowadays, I'm not sure whether the paraquat still, you can see the video. But the last time, yes. Okay, paraquat. Okay. This is what we study about the suicidal modalities. So, always go back to this question. For those working in the primary care, if let's say you're having a memory issue, cannot remember a lot of things about the suicide, just remember one thing, 7%. 7%. We keep talking about this during the undergrad school. This is a mnemonic to just give you the idea. This is not how you diagnose a patient with a suicidal. Just a guide, very, very general guides to tell you whether this patient is high risk or low risk. But always remember, every tools we are using always have a limitation. If let's say you're using these tools 7%, the score is not very high, but don't overconfident telling yourself that the patient is not suicidal. Okay, we have to see the overall picture still. Okay, just as a guide. So here the guide, the 7% is talk about the male. Those with young or more than 44, history of depressions, heavy history of the suicide attempt, use of alcohol or psychosis, poor family support, or they got a suicidal plan, single, or having a sickness. If this all scoring more than 4 or more, probably this gives you some idea. This patient might having some risk of suicide. But again, I would like to emphasize, this is not a diagnostic tool, just for the general guide only. For you encounter the patient, you can ask this whole patient within few minutes. Okay? Okay, so when we encounter a patient with a risk of a self-harm, always think about what is a safety plan. This is more important to the management. Okay? The safety plan, that means we as a therapist need to teach the patients how to recognize the early warning sign when the person is in crisis. And then teach them how to ask for help. The most example, very simple one, you just ask a person, try to list down what is the emergency contact number next of him, or what is the number of a government hospital. When he or she in crisis, direct call that number for help. It's very simple plan. Okay? Is that the safety plan I talk about? Okay? And of course, if a patient already diagnosed with a mental illness, and then they say the patient having bipolar depressions or schizophrenia, always tell the patients about the compliance and adherence to the treatment. Because I encounter some portion of the patient, after we treat a few months later, patient recovered already. Then they come to see me saying, Dr. Simon, I okay already right now. I don't need to take medication already. Then what happened next is that without the proper continuity of the medications, the brain chemicals started to be, disturbed again. So the next time, when the relapse time will be higher, the mortality will be higher. In terms of the severity also higher. So it's a tailored each patient's needs is a difference. So usually we will encounter the patient, better you go back to your previous doctor and then try to come up with a shared decision plan for the overall mental well-being. Alright. So what is a help good for me for those patients with mental conditions? Usually we will, as in the mental health discipline, we use a pharmacol, that means our anti-depressions or the sedative agents, or sometimes we use mood stabilizers or all those antipsychotics. It helps to the patient to control the symptom. The goal here is to bring back the functions. As a housewife, our aim is to make sure she can go out in the house, able to cook, able to do some cleaning work. Okay? As an office clerk, we hope that after the treatment, he can perform the accounting work and fulfill the task given. Okay? So it's kind of a different goal you have to set for your patients. Alright? So of course, with a combined therapy with a psychological therapy, or sometimes we call it a talk therapy, the effect is even better. We say that it's a combination approach. Sometimes we approach using the cognitive behavior therapy or the psychodynamic way, but all this is one of the options. If you know how to do it, you can offer. If you don't know how to do it, you just try to listen to the patients, try to support. You will give the patient a great help. Okay. So okay, I try to list down some general medication we use in the primary care or some clinics here. Just now one of our colleagues here mentioned is use of aspirin. Aspirin is a generic name for the escitalopram. The original drug is always called Lexapro by the Lundbeck company. Okay, so other medication which available in the clinic kesihatan government side would be the sertraline. I think you guys are very familiar who go to the clinic kesihatan. Okay, and some center by using the metazapine. Metazapine is a Remeron. It's a very good medication. It's under the category of a NASA group. And NASA group, that means it hit the receptor of the histamine. So you always have an adverse event of sleepiness. But we want to sleepy. Because sometimes patients say, I'm having a low mood, cannot sleep they are put in the next morning. Okay, and other medication is Prozac. This one, green, orange, purple pills. It's a capsule form. The good things about this one is this is a great evidence to use among adolescents with mood disorder. Prozac. But the only only part you need to remember is it got a very long half-life, more than 14 days to eliminate from your system in terms of the pharmacodynamic. So I have to be careful about the drug-drug interactions. If you mix with other like liver enzyme antibiotics medication like CYP, 3A4, 2S, have to be very careful about it. Okay? And the venlafaxine is our newer antidepressants under the group of SNRI. Okay? SNRI, that means it hit on the receptor of the serotonin and also norepinephrine. Logically, it can give fresh energy level. Because of norepinephrine. Alright? So far, you might follow me. There's a lot of antidepressants in this world. So I just give some common one we can use in our clinical practice. Alright? So here, I like to share the evidence because whatever I talk, you don't believe me 100%, always go back to the evidence. Okay? According to the evidence run by the Cipriani, he's a guru in the psychiatry field. He ever done the network meta-analysis for 21 antidepressants in the world to compare what is the efficacy level, what is the tolerability level for each drugs. Okay, he will give us as a clinician some ideas how to choose the best drugs for our patients. Okay, so here they are able to identify more than 500 trials in the citations involving of more than 100,000 patients who is depression. Okay, so next here. From here you can see in terms of the efficacy as compared to the placebo, usually there is a more evidence pointed toward the Prozac with a very big black lines here. Why is it so? Because fluoxetine is one of the earliest antidepressants in the market. If you already in the market so early, so a lot of the clinical trial will use the same medication to do the clinical trial, the RCT. Okay, but surprisingly, for those newer antidepressants like the agomelatine, fluoxetine, you can see comparably strong. That means efficacy is how good of medication can help to reduce the depressions. Okay, this is the efficacy. Alright. Next, we talk about the tolerability. That means the side effect of medication, how well the patients can tolerate the drugs. So from here, you see, despite the fluoxetine is very efficacious, but it also having a high level of the side effect problems. So theoretically, it's not very good choice. Because for every clinician here, I believe we want some drugs which can work very fast and with the lowest level of the side effect. Correct? Right? So here, if you look at here, again, agomelatine has the lowest adverse event, fluoxetine, okay, and also some mirtazapine here. The remember, just now I mentioned about remember. So this is the analysis want to tell you how strong it is, the efficacy and acceptability. But always we see at the top 5 agomelatine, according to this study agomelatine is a very good drugs which come with the least side effects. Okay, it always improve the sleep. Okay, followed by the fluoxetine, escitalopram. Just like you mentioned, right? Escitalopram. That means it's got not much of side effect, but we always go back to the clinical practice. If ever start aspirin, what is the patient usually will tell you after 2 weeks? The side effects. Yes, GI problem. Usually those SS are having a higher tendency of the gastric, blocking stomach, nausea, vomiting. If a patient having a concomitant of anxiety, it becomes worse. Become more anxious. Okay? So here is, I put it combined together lah. Acceptability versus efficacy in one block. This one we call as a network analysis lah, yeah. So we try to find something out of it. So the best one will be the 31. 31 referring to the voltiosetine. That means it's very efficacious. At the same time, it's having the lowest the tolerability issues. Okay. So here just give you some guide how to choose the best antidepressants. Alright. So in the psychiatry world, is always having some innovative change, yeah, in terms of approach to our newer medications. So right now, I'm here very fortunate to tell you guys we have the latest medication in Sabah here. Okay, we try to implement the latest antidepressant. For example, this is a Lapuda, or another name is we call it as a Burasidon. Actually, it's very famous in the other country already, but because of some regulation in Malaysia here, we bring the medication here land in. Okay, other drugs will become the Cipane, it's a Caniprazine. It's a very atypical antipsychotic which is very efficacious to treat the depression as well. Okay, followed by the Rizalti, and the latest one is the Spravato. I think all of you heard about ketamine, right? When you do your NS posting last time, many years ago, ketamine to reduce the sleepiness for those doing the operation. Correct, surgeon? Surgeon. Okay. So now the psychiatry field will try to implement to upgrade the ketamine become S-ketamine. It's an anomaly of ketamine, and it's always indicated for those patients with highly suicidal risk. Then we use S-ketamine. Just a one spray into the nostril, the suicidal thoughts will be diminished within 24 hours. It's very, very fast. But again, many drugs always come with side effects. We have to get the special training to use these drugs because you have a dissociation after administering. So usually my own practice here in Sabah, I will try to observe for at least 1 hour. Because the patient sometimes might having some confusion state, hallucination state. So we are there to support them to reassure them. Okay. This one just for the you guys to understand how the psychiatry will change very fast from year to year. We're always having a new medication to come out. And trust me, this one nasal spray only, you know how much it costs? Any idea? How much? Just a guess lah. What spray? Yeah? 2-3 ringgit lah. Oh, okay. So usually it's very costly. We try to lifesaver. For those patients is having a very acute crisis. We diagnose already depression with suicidal risk. This one spray is cost about 1,000. And then for each spray, we at least 3 doses. Yeah, these sessions. So it's very, very highly cost to the patients. So usually what I would tell the patients is that if right now we are mentally stable, just continue, but we have to do some preventive measurement to make sure you're mentally stable for a long time. We don't want to wait until last minute suddenly you're having a crisis and then you wanted to harm yourself, then you have to pay the higher price. We don't do that. Okay? We always go back to the community, try to educate more the people in the community, try to protect our mental health. I think this is essential in this approach. So last part I will talk about some cases about schizophrenia. Okay. So in the schizophrenia patients, usually go back to our basic anatomy. So what happened here is we believe that there is some involvement of the neurochemical pathway in the brain. Okay? For example, here is a structure of a VTA, and then go to the prefrontal cortex. Usually, in the schizophrenic patients, there's a diminish. That means a reduction of the function in that particular pathway. Okay? It gives rise to some negative symptoms. Okay, patient wouldn't talk anymore. He will know motivation of our life. Yeah, he will know energy. Okay? But schizophrenic patient always can hear the voices or having the hallucination. Look the ghosts around, can see the ghosts. Because something happened in the mesocortical area here. There's a hyper activating. It causes a lot of dopamine surge. That's why we give antipsychotic to reduce the dopamine. Just as simple as that. Right? So always go back to the basic. If you understand the basic, is for you to recognize it, easier for you to use the right medication with your patients. Okay? So in terms of the psychosis approach, in the primary care, if a patient comes to you with some psychotic symptom, if let's say it's within 1 month, usually we give a diagnosis of psychotic disorder. In 1 to 6 months, we call it as a schizophrenic disorder. If more than 6 months, provided you already rule out any other organic cause, you already done your blood test, everything normal, then you already can say the patient having schizophrenia. But everything will go back to the diagnostic criteria. Yeah. Okay, this is a DSM-5 criteria for the for the schizophrenia. Just as a very quick refreshment. Okay, so the person, if as long as having at least one symptom, must be either 1, 2, or 3, which is hallucinations, delusions, or disorganized speech, and then followed by another one out of these 2, then we say the person is schizophrenic. Okay, but you have to rule out other organic causes before you jump to this conclusion, say the patient is schizophrenic. Alright? So the symptom of schizophrenia in the very general approach, we can divide it into the positive symptom or negative symptom, depending. According to the study, if a patient comes to you very psychotic, talking to self, laughing to self, I'm more happy. You know why? Because the outcome is much better than those patients coming as a negative symptom. If a patient comes with a negative symptom, it's more difficult to treat. They usually is not responding to the first line of antipsychotic. We have to use a combined method or augmentation method to help them. Okay, so this having a very good prognostic outcome in a patient having this kind of symptom. Yeah, for those first onset of psychosis. So here we did some follow-up with a cohort study about the 10 years follow-up on the patient with chronic schizophrenia. Yeah? Okay. And then you can see that in the first episode in the 1990s, you can see this intent of the CT brain itself in terms of the volume, in terms of the ventricle sizes, and the south side, all that is kind of intact in a young patient. After 10 years later, what you recognize here is there is some changes. Dilatation of the ventricle, there's a flattening of the south side, there's a shrinkage of the whole brain volume. this insomnia, is it matter to us or not? Is it important or not to get a good sleep? Penting to get a good sleep. Why we need to sleep? At first place, we have never asked ourselves. Why we need to sleep? Recovery. Okay, some more. Wow, use a very high frequency. Circadian rhythm. Okay. Okay, it's our biological clock in our brain. Circadian rhythm. Some more. This young doctor. Recharge energy. Some more. Dr. Fitri. To feel better, yes, it's a sleep actually is good for our emotional regulation. That's why you can find out some people cannot get a good night of sleep, especially the boss because the boss always have so many things to worry about the company. That's why you just fight everyone. No matter it's you do the good thing or not, you cannot matter also. It's emotional regulation. Okay, and another part, good sleep is good for our immune system. If you always lack of sleep, always watch your Netflix, midnight, that means it's a high probability you get through or what? Immune system weaker. Okay? So this is very general. Why we need to sleep? So what happens if you cannot sleep? What happens? How to encounter that? Usually the patient come to your clinic. How do you help the patient with insomnia? I think it's the most prevalent condition. The patient come in, Doktor, tak boleh tidur lah. Yes, to find the cause, this is very important. To find the cause, we don't only treat the symptom of insomnia, but always try to uncover the underlying cause. If a patient come to the clinic, you don't simply just give the antihistamine. Cough syrup. I encountered a lot of from the GPs. Yeah. After the patient has this kind of addiction already, they come to me. It's creating a problem of addiction already. Not only insomnia, but dependency on the cough syrup, especially the codeine. Okay. So the learning outcome for tonight for this sleep talk, we will describe what is a normal component of sleep, and then describe why it is how do we diagnose insomnia in our medical field, and then select the more suitable medical intervention to help the patients, and try to learn something new tonight about the dual orexin receptor antagonist is another option for those patients with insomnia. Okay, so very quick. Normal sleep usually characterized by the REM and non-REM.
Yang kedua tu yang di tengah-tengah pola-pola yang penting untuk aku lagi. So yang lain tu mau ambil badan dia akan tutup.
Okay. This is a cycle. When you get into sleep for the first hour, you will from an awake condition become sleepy condition. So here we call it as a non-REM, dividing into M1, M2, M3. So usually here consists of the 4 stages of the non-REM sleep. So usually you will get longest in the initial 4 hours. You can see here because you always go in the cycle like a 1, 2, 3, 2, 1, and then in transition it is called that rapid eye movement. Okay. So according to the sleep study, most of us as a normal human being, our REM sleep is getting longer and longer, especially after the midnight. That means from 4 hours up to 8 hours. Okay? So some patients, they're having the problem of sleeping. Usually it's happening in the early stage. They cannot go into the deeper sleep. They cannot go from M1 to M2. We call it as a difficult to initiate sleep. Okay? So some patients, they can initiate, but after midnight, they wake up. After they wake up in the middle of the night, they cannot fall back to sleep again. We call it as midnight awakening insomnia. Easy to remember. So another type of patients, they can go into sleep, they can maintain the sleep, but they wake up early. Usually happen in the elderly. So I already explained 3 types of the insomnia. The last type, which is a very not many people aware that is that the whole night you can sleep. You wake up on night, but you cannot get the energy. We call it as a non-restorative sleep type of insomnia. And this is usually under-recognized by most of us. Yeah, that means in terms of the sleep duration, it's normal. But then in the next morning, I still feeling very tired. I still feeling cannot focus to do the task. Non-restorative time. Okay? So here is a talk about the normal physiology of the sleep, especially on the newborn. Yeah, whoever ever encountered with the babies, how long are the babies sleep usually? For the first month of life. Yes, our pediatricians.
Mengangkat depan ni.
The age 18 to 20 hours. Okay, so that means some baby only got 2 jobs only. Sleep, eat, and also berak.
Jadi aku mau bawa speaker.
So by the age advancing over the time, the brain structure change, the time of duration of sleep is getting lesser and lesser. Okay, like a normal adult like us, usually studies say the average mean time of the sleep duration is about 6 to 8 hours. But this is again just for the general advice only. Some of my patients they sleep only 4 hours, enough for them already. Some patients might need to sleep more than 12 hours. Only they say is considered normal adequate sleep. So it varies depending on the individual. Okay, alright. But always remember, there's a lot of factors affecting the duration of sleep, the quality of sleep. Okay. So, in a survey of about 2,000 Malaysian adults, we reported more than 60% they ever encountered with sleep issues. So here, they said about 2 out of 5, they said having at least 3 times of insomnia every week, which is very common. 1 out of 3 having chronic insomnia without daytime consequences. Okay. And then the rest of it having insomnia with daytime dysfunctions. I mean, they cannot function as a student, as an engineer, as a lawyer, they cannot function anymore because of the lack of sleep. Okay, so it's very prevalent. Depending again, as a doctor, no matter you work in the primary care, you work in the specialist center, yeah, how we want to help our clients who are sitting in front of you. Do you want to address the insomnia issue as well? Yeah, I think it's very important. So here, just now I tried to illustrate about the type of sleep. Okay, so here is usually the 24-hour cycle. When we get in the bed, lights off, and then if you have a problem of falling asleep, problem staying asleep, and wake up in the midnight, or wake up too early, this is all the types of insomnia. Okay. So that's why you're having this, all the symptoms of the fatigue, somnolence, impair in your cognitive, mood become very bad, irritable, and also the depressive anxiety symptom. Okay? So in terms of a diagnosis, how do we diagnose a person as a clinically significant insomnia? So this is according to the DSM-5 criteria, you must have a symptom at least 3 times a week for 3 months. Yeah, for 3 months. And then there is an impairment of the function. Then you only can say it's insomnia. Remember the earlier school day, our professor teaching us about the insomnia can divide into primary insomnia, secondary insomnia. Yes, we still take that into account, but now no more. Because it's very difficult for us to identify the causal relationship. Actually, whether it's a depression cause insomnia or insomnia cause a depression, no one can answer that. Like you asking me, where is the chicken and egg? Yeah. So we already abandoned the classification between the primary and secondary. So the easier one is go with this one, DSM-5 or the ICS, D3 with all this symptom. At least 3 times a week for 3 months, then we call it as a clinically significant insomnia. Alright? So according to the American Academy of Sleep Medicine, they published a guideline on how do we evaluate or manage the chronic insomnia disorder. So here are the few key components when you see the patient who is having a sleep problem. Always take a very good detailed sleep history, and then plus other history here included medical, psychiatric history, what is the medication used by the patients, how is the social functioning or family occupational history, and eventually perform very quick physical examination to run other medical course plus medical mental health assessment. And here I list out a few of the commonly used the tools. What do we recommend to the patient? Usually, as a subjective reporting method, you can ask the patient to do the sleep web diaries. That means they just to jot down what time I sleep tonight, do I dream or not, and what time I wake up tomorrow morning, do I feel refreshed or not. Something like that, very simple. But just try to record every day. Then next visit, you see the patient progress. Then the second one is you use some questionnaire. This is a very fast one. It's based on the patient self-reported. The third one is this one, we call it as a wristband. Some patients like to wear the wristband, but different wristband with a different technology, different algorithm. Because some wristband you give you the scoring, whether tonight, I can score 90 points or not, based on my sleep quality. But tomorrow, suddenly I get 89 points. I started to worry already. Why I cannot achieve 90 points? So it's a wristband we can use as a guide, but don't over dependent on it, because every brand in the market will use a different algorithm to give rise to the scoring. I will be honest to everyone here. Some of my patients they are too reliable on this kind of tech, the wristband, smart wristband, smart band. Then a lot of them become worsening of anxiety symptoms. They keep occupied. After they wake up in the next morning, they can think, tonight, can I get a good sleep or not? So this person keep ruminating in their brains for a whole day, cannot work anymore. Okay? And another one we can recommend the patient is to do the sleep study. For those patients who is suspecting having some obstructive sleep apnea symptom, snoring, sudden breathing during the sleeping time. You can recommend usually in the government hospital to do the sleep study 24 hours. So, what is the treatment approach? How do we try to enhance, try to improve the sleep quality? Back to the basic of chemicals, we use several methods. Either you want to promote more sleep in the brain, or you want to weaken the wake center. Because our brain got 2 buttons only. One button, if you press, you keep awake. Another button you press, you directly become sleeping. So in order to help the patient, we want to press the button of can you sleep? And we try not to touch the button to make the patient awake. You get it? Okay? So back to the chemical things. Which chemical can promote our sleep? Usually it's a melatonin type and also the GABA. Whatever the substance you're taking, if you can hit the GABA, sure you become sleepy, right? Okay? Those are GABA agonist medications. Okay? If, just like I mentioned, right, we try not to touch the button to make you awake, which make you awake. So, right now, the new drug company, like our tonight, they try to invent another new medication which to prevent inhibitor of the orexin. If you inhibit the orexin, that means your body will become sleepy. Because orexin is made you energetic, you try to inhibit it, you become sleepy already. This is a new approach. Okay? Another one is an old approach. Usually would like to use by a lot of some of the doctors here is an antihistamine. histamine makes us awake. If you give antihistamine, it makes you sleepy. As simple as that. Yeah. In terms of pharmacology, okay. So here is illustrating about the orexin. What is the level throughout the day, 24 hours? Usually orexin, after the sun's lights on, during the daytime, the orexin level is highest. Okay? And then after the moons come out, and then the orexin will be lowest. Okay? So now, as a doctor, we try to play around this kind of physiological changes. We try to suppress the orexin during the night time, so naturally, patient will feel sleepy already. Very natural. Later I will share about what is the good things if you use the orexin receptor medications. So of course, besides using the medication, this I think is very important. Always educate our patients what is sleep hygiene. That means without using medication, what else are the lifestyle modifications we can be applied to help the patient get a better quality of sleep. Okay? And then of course some patients might require some CBT That means talking therapy to understand their cognitive errors. As I mentioned, right, a patient keep worrying after he wake up in the morning, he already think oh tonight I cannot sleep, sure confirm cannot sleep. This is a cognitive errors. We got a way to address it. Alright? So another common drugs we are using in terms of the primary care, usually we tend to use alprazolam, or some Asian center we use lorazepam. Okay, this is considered as a very short-acting benzodiazepine. Its functioning is trying to activate your GABA. Remember just now, GABA kalau you activate must be sleepy. That's why the patient will say, betul lah. After I take the something, I feel very sleepy because GABA has been activated in the brain. But most of the patients don't know about the long-term effect of GABA. Macam benzos use lah. The one most important thing is an adverse effect. If you use too much of a GABA, like the benzodiazepine medications, usually patient will tell you, doctor, what happened in the next morning? I feel very tired. I feel my brain still confused. I don't know, I already wake up. Or some patient will say, doktor, badan saya semua sakit lah. Macam lemah, tak boleh gerak. This is a bad thing about GABA. So the most dangerous part is the GABA, using the benzol is the risk of addictions. Addicted, or we call it as a dependence. How we say the drugs can cause a dependency is based on two things. That means, number one, you need to take higher dose over the time to achieve the same effect. Number two, if you stop using the same medications, it can cause some withdrawal. Kalau ubah itu menyebabkan two conditions, we say this drug is harmful in terms of addictions. Alright. So besides the benzodiazepine, some centers also use Z drugs like the Stinox. Rather than Stinox, enjoy patient ambil the Stinox. Like the first one, get one tablet. Second one, upgrade 2 tablets, 3 tablets a night. So it's a Stinox dependence already. Because the Z drug also got this kind of this. Okay. In our psychiatry field, we use other medication like low dose antidepressants or antipsychotic, but it's all is considered as an off-label use because some medication it can hit the antihistamine and hit the GABA receptor. That's why some of the psychiatric medication is helping sleeping. Okay, all right. The last one is a melatonergic agonist, okay, which can promote the sleep center. So here is some the Lancet, published one of the paper in the last year. They compare in terms of pharmacological intervention to handle the acute or long-term management of insomnia patient. This is a network analysis again. It compare all the drugs in the world, see which one is good, which one is bad. Alright. So what the medication they included here is a benzodiazepine, Z drugs, melatonin agonist, orexin antagonist, antipsychotic and antidepressant, up to the 170 trial have been included. So, what is the summary? We saw that the lemborexant is one of the orexin antagonists. Indication to have a favorable profile of insomnia, it can help for people with a sleeping problem. But there is some concern of some drugs can cause substantial adverse events. Okay, and poor tolerability have been shown in those benzos. So remember, don't only use benzos to treat the insomnia cases. According to the study, there is no any long-term data to support it. We always tend to go back to the cause why the patient cannot fall asleep. Okay. Overall, there is no much of the benefit is the use of antihistamine. Antihistamine, no benefit. In fact, you can use more other adverse events. You makan banyak antihistamine, there's a risk of weight gain issue. So, how do we go forward? If you already understand from the study said that lemborexant can help the insomnia, we try to look up clinical data whether support or not. So here is some illustrations about the orexin receptor. How do we react within the drugs? In our brain, usually we have a lot of receptors, but more specifically is the OX1R, OX2R, which is a blue color, pink color here. Okay. So what happens is that when the orexin producing the neuron, it will give the signal to all these of neurons. We try to inhibit sending the signal. Okay, sorry, it's a bit dry when we talk about this kind of things. Especially this really nice line. So I make it fast. Basically, lemborexant is a medications to help us sleep in terms of blocking all the wake-up receptor. Okay, that's all. And then this is some study to support lemborexant comparing to the other drug like the Stilnox, whether it's effective or not. Okay. So in terms of the study, we found out that in the timing of insomnia symptom, if you use lemborexant, the key efficacy measurement for the insomnia symptom actually is improved. That means you use lemborexant, the patient can sleep faster and sleep longer. This is the rest we can just skip it. Okay. Here's some medical data to support that. Because eventually I would like to do a very brief test sharing about some of my patients. So this is how it looks like, the lemborexant. Okay, or day before we call that. It's a 1 tablet 5 mg. You can take it during the night time. Okay, the patient will feel naturally induced sleep by himself. Alright? And okay, very good. So here I would like to share some studies on my own clients from my private practice. I got this 44-year-old Chinese lady who worked as an accountant and then referred by GP for persistent anxiety or long-term Xanax. Very common. Xanax. So they got a family history of anxiety disorder, which is a mom, or medication as well. She always feeling anxious all the time, worsening for the past 1 month because her son get admitted into the hospital. And then she also has some panic symptoms, insomnia for more than 10 years. She cannot initiate the sleep, she cannot maintain the sleep. That means she always wake up in the middle of the night. And eventually she refused to take more Xanax because she feels the body always very not specific pain, heavy and tired. This is a patient, complain if you take the long-term Xanax. So what happened is that we treat her as a panic disorder with underlying insomnia for years. Started on the Ritalin, which is antidepressants, and then we go 5 mg. So there is a fast improvement after 3 weeks. Okay, controllable anxiety symptom. She can work faster than before as an accountant because you need to do a lot of mental work. Okay, and she commented that, "Doctor, I haven't experienced such a good sleep in the past 10 years." This is what the patient told me after 3 weeks. This is how the medication works as compared to Xanax. And then now the patient switched to Derigo. And then the husband surprised her, "Wow, my wife look energetic and younger than their skin look younger, look prettier. So we shall let them sleep more. Sleep So the second case is talk about the Madam KK. This is a elderly woman. I got this Chinese auntie, 70 years old, come with her husband, no guess of anxiety depression for past 20 years. Under one of a private psychiatric follow-up, she had been unwell for the 2 years triggered by loss of family. I think got 3 family members consequencing pass away within a few months. So this is a big impact in her life. So subsequently, she having an insomnia for a few months, perpetuating by a very non-specific somatic symptom. She always feel inside the tummy there is something move. Like she cannot describe to me what is the feeling like. It's a very vague feeling of something moving around the tummy, and then something moving around the back. Very painful, very numb of the legs, like that. Very disturbed sleep. She always wake up in the middle of the night until morning, cannot sleep. Very irritable because cannot sleep. Okay? And then went to the several GPs, given Xanax again. Because GP like Xanax. I don't know what's the specific reason for that. Okay? Increase in terms of frequency and dosage. So what happened? She upgrade From Xanax, she upgrade become clonazepam or ribopam. Ribopam is another stronger benzodiazepine. She can take up to 4 mg a day, which is a high dose for me. Especially she is an elderly woman. We usually not recommend to use a high dose benzos in elderly. You know why? Number 1, there's the risk of fall. If the risk of fall, there's always the risk of fracture. Number 2, use of a high dose benzos in elderly always associated with a cognitive impairment. This increased risk of dementia, according to study. So try to avoid. Okay. So went to another physician. Okay sebab specialist kan. So bagi SSRI, Prozac, but still she cannot sleep and anxiety. And then given the Lexapro high dose, gastric pula, always having a tolerability issue. So she come to see me and then asking me, doctor, can you give me one magical drugs? Make me calm down now. She very fidgety, moving in my room around, very very anxious. Elderly woman come with her husband, right? Because she said I cannot sleep, something moving around my tummy, very bad symptom. So eventually I treat her as a GAD with prominent insomnia. Give her some Ventilix, add on some low dose of quetiapine. Clonazepam, I managed to reduce it, just a half tablet only, BLN, and then there we go, started. So there's some improvement. You can see that clinically after 3 weeks, mood becomes slightly better, thoughts still overwhelmed by the somatic symptom. So eventually I add on a very low dose of Remeron, combined with Davigo and quetiapine. And patient say she can get a good sleep after that. It's a very complicated case this. Right? So the last thing I would like to share tonight is the use of Davigo in underage. Yeah, underage is less than 18. So I got this 13 years old boy, Form 1 student, no care of autism, and then also depression under government hospital follow-up psychiatry. He was started with a Prozac, which is a fluoxetine for depression, but complained of a severe headache. So eventually changed to Lexapro, gastric again. You see, Lexapro always associated with gastric. Okay, so I went 3 years, depression symptom, and then weight gain 15 kilo. Okay, changed 3 school already, not helping. So he eventually refused to go to schooling. Always stay at home, don't want to talk to parents at home. Eat a lot, weight gain a lot. Okay, and then worsened for a few months, feeling hopeless about life. Started to harbor some suicidal thoughts, want to give up and stuff. Yeah, attempted to jump off the building, but stopped by the family. So brought to me with a prominent insomnia. She cannot start to sleep. He cannot maintain the sleep, and he also got early awakening. This is a worst combo. Cannot sleep at all. The suicidal risk moderate. So cover with a low dose of antidepressant together with the Pristic. Pristic is SNRI, S-venlafaxine. Give people some energy. Okay? And lorazepam. After 2 weeks, mood improve, but still headache, still insomnia. So I off the lorazepam, change to Devigo. So what happened is that he cannot tolerate the Ritalins, so I have to combine with the Luvox, maintain with Devigo. So after I think 1 month, I see him as outpatient, no more suicidal thoughts, can talk to more friends, become more socially approachable, and willing to join more sport activities, and of course, the sleep pattern improve, quality better, and eventually, parents is very happy with current treatment plan. Alright, so this is a very brief intro about the daily clock can be used in any age of patients. So, any question from the floor before we end the session tonight? Yes. Apa ubat? Devigo. Actually, according to the study mentioned about the Devigo, whether it can cause addiction or not. Yeah, I think there's a published Victoria study. They study about the addiction properties about Devigo. So far, there is no any strong evidence that it can cause addiction like a benzodiazepine. So it is safe to be used and it can be continued anytime.
Yes, this is used in the patient that evidently sleeping because of
That means patient ada masalah sleeping.
because of shift system.
Shift system. Oh, okay. So it's again I have to understand whether the shift system is it running every day or have to change every week. Yeah, it's already disturbed on the circadian rhythm as you mentioned. Yeah? So Devigo is not evidence can helping in terms of circadian rhythm. If we talk about circadian rhythm, actually this is another antidepressant. We call it as an agomelatine or paradoxan. This proven can regulate the circadian rhythm. But Devigo is depending on you to look for the cause first. Yeah. But one thing is that every medication always comes with an adverse effect. Yeah. So one of the very prominent from my clinical point of view, that we have been using the Devigo for numerous patients. Some patients mainly telling me that after they started Devigo, they were having some episode of dreaming. Yeah. Dreaming. Why dreaming? Because we only dream when we get into the deeper sleep, especially the REM sleep, rapid eye movement sleep. This is where the Devigo will come. It brings us to the deeper sleep. That's why REM is still active, but you cannot move your body. Patients still can dream. But most of them, they said they able to regain the energy, the focus in the next morning. So another rare complication about Devigo, some patients do complain about the somnolence in the daytime. But it always is a dose dependence. So usually I would recommend only use 5 mg. Enough. We don't push higher. Okay. Alright. Any other questions?
Yeah.
Yes, Rahul.
Although I think it might be a long time before we can adjust to this.
Oh, so yeah. It's so I heard the good news from the company. They said Devigo have been launched, go into the blue book.
So we have not gotten the blue book yet, but what happened is that I think in some of the centers, so for example, Hospital Kuala Lumpur, they have been raising KPK special permit to use Devigo in the center. So I think quite a number of, at least I think 1 or 2 patients has gotten the approval to use it initially. But of course that is subject to approval by the head of department and also the hospital pharmacist.
Okay.
Yeah, there's a chance for government service. Just be more patients.
Yeah, just wondering so far in your experience using this, is there any investigation can impose
Dr. Rahul is asking me about any risk of overdose of Davigo. Yes, I would say yes. Always when the patient feels some medication have intense sleep. If let's say tonight I having quarrel with my boyfriend, I feel very frustrated in sleep, so I try to overdose then there's always a risk. Yeah. So what I advise, especially for the young people, I would advise the family members, others to take care of the medications. Don't let the patient take a big bunch of medication by themselves. Yeah. No matter if they overdose any medications, not only Davigo. Some patients even overdose with antihistamine tablets, Meriton, just because they cannot sleep, or just because they are in crisis. Yeah. But still back to our clinical judgment. If you think the patient is at higher dose, higher risk of overdose, probably you can give the medication supply about 1 or 2 weeks time. Ask the patient to come back again, try to troubleshooting why they are in crisis. This is what my approach.
The toxicity is similar in
The toxicity because it act differently. The benzos is act on the GABA receptor. So this one orexin is act on the orexin receptor. So in terms of the toxicity, I think it's a different presentations. This one probably the other medical advisor.
Yeah. So probably I can share. Also for Davigo, what happens is that there is a patient that was dosed up to 75 milligram, and the patient what happens is that for this 75 milligram, they experience more higher incidence of somnolence. It means that degree of somnolence was much higher as compared to the normal dosing. But it's same up to 75 milligram, just higher somnolence level. But of course, I think what Dr. Simon pointed out, very important is to make sure that the patient are not by like 1 whole years on by or something. I think that's a very good practice.
So mainly we worry about the somnolence. When you think the patient having the risk of somnolence, try to advise patient not to drive daytime, not to operate the heavy machinery, things like general advice. And for your information, actually, Davigo is one of the medication can concomitant use together with alcohol.
Can use it.
Can use together. There is not any increased risk of overdose or what. As compared to benzos, benzos is our CNS depressants, right? If you combine benzos plus alcohol is also GABA. So why you want to add on more GABA? Of course, some patient will have bradycardia or respiratory distress after that. But Davigo you can mix because it's involving a different chemical pathway. Okay.
Then the patient got a lot of anxiety.
Yes. Yeah.
Is Davigo for the role to reduce anxiety?
Good questions. There's ongoing research. We try to understand about anxiety, about depression, about dementia, whether the orexin receptor play any roles or not to cause those symptoms. So the research has been ongoing. I think the data is kind of promising. So they are saying that right now with limited data, there is some evidence use Davigo to control anxiety, depression. In terms of the mono and mind theories.
Yeah, but Rahul, in Malaysia, currently Davigo is only indicated for insomnia. Yeah, because all this clinical trial has not been we have not gotten any approval for the indication other than insomnia in the whole wide world currently.
Alright. And is FDA approved for all the age groups?
Sorry?
Is it FDA approved?
Yeah, it's FDA approved for the insomnia. So insomnia, all countries will have that indication. But I think as Dr. Simon pointed out, there are trials going on for other group of patients, but nothing has been approved yet as of this point in time.
For adolescent also?
So Davigo in Malaysia is indicated for 18 years and above currently. Yeah.
So 18 years and above according to the Malaysia regulatory consensus, Davigo is used for more than 18. Yeah. But what you see just now I do the case sharing is some unique cases and then we call it as an off-label use because you have been trying other medication already doesn't work, so Davigo it comes. Right. Any other questions?
The starting dose is
Always, if you are worried about the medication dose, especially those underage, underweight, you can start after the first 2.5 mg. After 1 week, you can taper up slowly. But I have to advise the parents about the risk of somnolence daytime. Okay? Right. If no other question, maybe I will pass the floor back to the organizer, DSNC marketing. Alright, thank you everyone.